Thank you, Chicago. Welcome, everybody. It's 12 o'clock. That's the time. So it's time for this month's QI Community Webinar. I'm Tony Lemke. I'm in Austinville, northern New South Wales, where it's still summer and a beautiful 26 degrees, as you can see out the window. Now, we're joined in a special presentation today by two of our friends from America, Julie Johnson and Paul Plsek, who I'll get to introduce themselves. So, Julie, where are you and what's your current role, please?
Hi, I'm Julie Johnson. I'm at Northwestern University in Chicago, and I'm a professor in the Department of Surgery and the Center for Healthcare Studies. And in the Department of Surgery, I'm conducting an evaluation of a large learning collaborative around surgical improvement.
Cool. And what's the weather like in Chicago, Julie?
Well, we're at the end of summer, and let me translate to you in Australia. It's 19 degrees right.
Okay. That's not too bad for Chicago. And
it's
Paul,
night, so it's 9 p.m. here.
9 p.m. Well, thank you for joining us so late at night. And Paul, where are you and what's your role at the moment?
I happen to be in Washington, D.C. In the U.S. at the moment. I'm a management consultant and independent management consultant. I'm also a innovator in residence at the MedStar Institute for Innovation, which is here in D.C. I'm the chair of innovation at Virginia Mason Medical Center, and I do some work in the UK, and then I'm looking forward to coming down to Australia and New Zealand, where I do a lot of work with co-op with TAEA, and proud to be associated with the Improvement Foundation in the conference is going. Temperature in D.C. is probably about 20 degrees Celsius. It's 10 o'clock at night. It's a beautiful starry night with a beautiful moon out. It's a nice evening.
Well, lovely. And could you say hello to our friend Obama for us, Paul, while you're there? And Michelle.
Yeah, I was saying before the rest of you joined that I'm about 6 or 8 blocks from the White House, but I don't get to see Barack Obama very often. He doesn't come out to walk the dog or anything.
A shy fellow. Paul,
yeah,
we're joined and we welcome 50 change leaders in Australia who are making up the audience today. These are people who are clinicians and managers who are trying to lead change in both primary care and hospital systems and seeking to improve, particularly at the moment there's a theme of improving integration in healthcare. I think that's probably an international, universal theme about trying to improve integration in healthcare. So about 50 people online, and there'll be more joining us shortly, I'm sure. So people, our friends online, if you have any questions as we go for Paul and Julie, if you type them into the chat panel, and we'll deal with them as we can. Paul, we'll start with you. We thought you've done a lot of study over many years of the science of change, of what makes change and improvement effective. I wonder if you could give us a bit of introduction to some of your understanding of how change works and how we can facilitate change, particularly as it applies to healthcare.
Yeah, great. Thank you, Tony. And if I could get the slides that are up, we thought we would, for those of you on the call, we thought we'd each take about 5 or 7 minutes or so just to share one idea or one key concept. And enabling and engaging people in sustainable change is an exercise in psychology. It's about engaging people's minds in things. And one of the illustrations that I use to help people get a grasp of how they approach change, how a change agent, what's your theory of change is the question. There's a difference between throwing a rock and throwing a bird. You see on the slide there two folks with one has a rock in his hand and one has a bird in his hand. And they both want the rock and the bird to change. They want them to be in a different place when it's all said and done. So what do? Well, the guy with the rock throws the rock. So if I can get the next slide. And if you throw a rock, a rock follows a predetermined path. Don't go on to you spoiled the punchline. If you throw a rock, the rock follows a predetermined path. Once you launch it, if you know the weight of the rock, the speed of your hand, the angle that it leaves, if there's any strong wind current in the vicinity, once you launch the rock, The rock can only land in one place. It's mathematically determined. But think about the fellow who's got a bird in his hand. And so he tosses the bird, and where does the bird go? Next slide, please. The bird goes on a path anywhere he wants. And the question for you as change agent is, which one of these two best illustrates the process of change in your organization? And you know, we spend a lot of time trying to launch change just right. Not on to the next one yet. We spend a lot of time trying to launch change just right. We spend a lot of time imagining that somehow the change will follow exactly the path that we expect it to follow, as if we're throwing a rock. When in fact, what most people's experience of change is, you launch it and it takes on a life of its own. It's much more like throwing a bird. Well, what if you really do want the bird to land in a particular place? It's the best thing for the bird and for everybody concerned. What could you do? The launch doesn't matter so much. What might matter is whether or not you've placed something attractive at the destination. So next, click on the next slide. And so if I wanted to get a bird to land in a particular place, I'd have to study the behavior of birds and realize that they naturally, on their own, tend to land where there's bird feed. And my position as a change agent is not so much in launching the change, but it's in creating the attraction for the change. How do I how do I tap in to the natural pattern of bird behavior, in this case, to attract for change? So all the work we do to plan the details and the rollout of change as if it's going to go exactly according to plan, like we're throwing a rock, often fails. And what we'd be better off doing is launching a change and really concerning ourselves with how do we attract people to be engaged. So next slide, please. Next slide, please. Next slide, please. I'm sorry, I'm not seeing it on my screen. Maybe it's there. Tapping into natural attractive patterns. It's not so much that people are resisting change. It's that their behavior revolves around patterns that's rooted in their basic values, such as a desire for professional autonomy or a sense of what's right for their patients. This is so critically important to understand. And I don't actually believe in the concept of resistance to change. I believe there's a behavior that we label resistance to change, but I believe that labeling it such sets us in an us versus them. It's a negative thing. People aren't resisting change. They're doing what they think is right, according to their values. Not your values as the change agent, but their values as the participant in change. So if you go on to the next slide, to take this and to play this out, how do we achieve sustainable change? So I hope you have a slide on your screen that says achieving sustainable change. It's not quite, there it is. What change agents or advocates bring are drivers. We state the case for change, and we're convinced, because it fits our values, that the case for change ought to drive people to want to make it better. And if we're enlightened, we provide some enablers for change. We provide some pump priming resources, some knowledge, or whatever else it is. But what do the stakeholders bring? They bring two important things: their values and their discretionary effort. You see, they're listening to our case for change through the filter of their values. And it's only when we touch one of their values, not one of our values, one of their values, that resonance occurs. And there's a motivation, a desire, a will to change, such that it unlocks the discretionary effort. What do I mean by discretionary effort? You know exactly what I mean. Unless you can stand over each and every individual and beat them over the head with a stick, you can't make people do exactly what you want them to do. They have to decide that what you're asking them to do makes sense to them, that it's the right thing to do. And when they decide it's the right thing to do, because you've managed to state the case in a way that resonates with their values, that discretionary effort, plus the motivation, the will to change, plus your enablers, creates change. And so on the next slide, some of the values, I did a study several years ago looking at the literature on the values of health and social care professionals. So I hope you have a slide up that has a series of values on it. There it is. What you need to be listening for and looking for in the people that you're trying to influence is, what are their 2 or 3 key values? Some people are motivated by altruism, doing good for others in society. Others might have a strong value of mastery. I'm a good professional. I'm a scientific thinker. Show me the evidence, and I might be convinced. Other people have a strong value of autonomy. I value having a say and a choice in how things are done. You're dealing with people who have a strong autonomy value. You have to engage them in the process of deciding what the change is. You can't just tell them what the change is. Comfort and control, you can read the others, and I'm sure we can download these slides or email them to you. The point is, on my final slide there, if you move on to the last one, that as a change agent, you need to shift your mindset. When you're frustrated at others because you've made your best case for change and they just don't get it, and as change agents, we just keep giving the same cases, we keep showing those same PowerPoint slides and giving the same case for change over and over again, and we get more and more frustrated with those resistors. What I'd like for you to do is to stop and look in the mirror and look at yourself and say, what is it that perhaps I don't understand or get about them? Maybe I don't understand their values. Maybe I need to listen to what they're saying and find a way to tap into those values that they have. The evidence is that if you can tap into people's basic values, they'll be with you and they'll put that discretionary effort in. So we can talk more about that as we take question and answers. That would be my one important point to make about the leadership of change.
Gee, Paul, thanks for that, Paul. And that's a fantastic point, and one I don't think we think about enough. It reminds me that Dale and I were talking to Doug Eby in one of these webinars, and if a patient was referred to as being non-compliant, he would smash the desk and get very upset that we would have to hide to accuse someone of being non-compliant. And it's similar to that, based on our clinical practice, is similar to what you're saying. To label someone as non-resistant means that we haven't tapped into what attracts them and what they value and what guides them.
They're not non-compliant. They're just doing what they think is right for them and their life. And if we can't explain it to them in a better way, then it's our responsibility as much as theirs, if not more.
So Rachel asked a question as part of, while you were talking, Paul, about how do you resolve it when everyone agrees on values and vision, yet still wants to act independently, and to some extent your final slide has answered that. If they're not acting in the way that you were hoping, then you need to think more about what you don't get about them.
Yeah, and you can't ask people what their values are, because they often will tell you what they think you want to hear. But what's important is that the values are revealed in behavior, and if people act from a value of autonomy, in other words, they're constantly questioning who was involved in this decision. Why wasn't I consulted? They can put their hand up to a piece of paper and say, yeah, they want teamwork and collaboration, but the behavior is such that their basic value is around autonomy. It's the behaviors that tell us about values. And it's not that they're being deceptive. They may not even be aware of it. They may actually believe that they're all for teamwork and collaboration. But their internal mindset is autonomy, and that's okay. We have to accept that about other people and find a way to tap into that, involve them such that they feel like they have had a role in it, and then they'll be on your side.
So Dow's asked another question, which we'll come back to about even when we do get them, we get a common pathway to action. We might come back to that, Dow, because Julie's going to thank you, Paul, for that, and we'll come back to you with further questions. And
Great.
Julie, you might turn your
Thank
webcam
you.
back on. And Julie, you're going to give your overview of approach to this issue of facilitating change.
Yes, thank you, Paul. That was wonderful, and I love that metaphor for thinking about change. It's really very helpful. And so, one thing that I like to think about, I know that when I am engaged in a project or I'm engaged in an improvement activity, I am so excited and I am so engaged. But then it's like, what can I do to engage everybody else? And then I started to think about this from their perspective. It's like, well, when was the last time that I actually felt engaged in somebody else's project? I hear other people at work talking about their pet project and the thing that they're excited about, but it doesn't necessarily engage me. So, when I turn that around to my work, what makes me think that I'm going to be able to engage my colleagues? So I like to ask, I teach here at Northwestern, and I teach mid-career clinicians who come back to school to get a master's degree, and they're all excited about what they're going to learn to do about improvement. And I ask them, I say, well, is there a time when you felt engaged at work? And what is it that actually led to that engagement, if they can even come up with a time? And it's actually quite rare that these students of improvement and these clinicians can talk about a time when they've been engaged. They feel engaged in their own work, but they don't feel engaged in other people's ideas. So what is it that we can do and can tap into that? And a lot of it is what Paul was talking about, how we actually start to attract people to our ideas. So next slide, please. So this is from Butterworth talking about 9 reasons why people engage in change. And I think this summarizes a lot of what Paul says. Well, their values support it. They think the change is going to be worth it. They see what's in it for them for actually making the change. They think it's possible. It's actually something that they can envision that they're going to be able to do. And of course, you have to be ready to make a change, as we know about the several models for change. Is that you have to be at that point where you know it's important and you think you're going to be able to do it. And there has to be a good plan, and there has to be adequate support. And I think a lot of that is that we have these improvements that we get started, but the organization, the larger system, is not able to support the work that we're going to do. And you also need to have reminders about the resources that are available to help you through it. And finally, I think it has to be fun. If it's not fun to be doing this work, I think it's, we slowly go back to the daily grind and doing what we've always been doing. Next slide, please. I'm waiting here for my next slide. So I want to talk about some myths of engagement. And I think these are important to think about. One is the myth that if we show people the evidence of why they need to change, just showing them that burning platform, that's going to be sufficient. And we know on research around change that showing the evidence is not really enough to disseminate the change into everyday clinical practice. The next myth is that everyone engages at the same time. And I know a lot of work that has been done about the diffusion of innovation, and Paul could speak to this because he's done some of that work, is that everyone's not going to be changing at the same time, because that's not the way that diffusion works. And the next myth is that the same message works for everybody. We all have different styles of learning, and so you got to figure out, you have to target your message. So how can you best communicate your message about change to different people? And so you have to figure out different, whether it's these face-to-face webinars like we're doing, or whether it's print, or whether it's bringing people together in a town hall discussion. It's how do you target multiple people? You need to have different messages. And the fourth myth is that every intervention is equally easy to implement. We know from our improvement work that there's some easy ones to do, some low-hanging fruit, and then there's some really big, hairy improvement ideas that takes a lot of work. And I found this wonderful resource, and I don't know if you have found this. It's called an improvement guide from the American Hospital Association and their Health Engagement Network. And this is just a wonderful resource, and I provide a link to it at the end, or I can send you the link so you can download this document and get some more ideas. It's a great toolkit. Next slide, please. So in counter to our 4 myths, we also have 4 rules of engagement. One is connect to the core, and this is going back into a lot of what Paul said of understanding the values and how your project, how your improvement ideas fit into the bigger picture, and how in thinking about how everyone contributes to the project that you're working on to make a difference. The second rule is to engage the engaged. So look for people who are already opinion leaders or who are excited about the work and who can really lead and help lead. And it doesn't have to be someone who has a formal title in an organization. Sometimes those opinion leaders are not the directors of the departments or the leads, but they can be other energetic people who support and believe in these ideas. And so, and thinking about how to use those early adopters as spokespeople to spread the word. Next slide, please. And as I talked about before, about understanding how to customize the communication to support the engagement. And the fourth rule then is to segment and to align. So develop an organizational goal and enlist the participation at all different levels of the organization, the microsystem and the mesosystem and the macrosystem. And focus on an area where you think you're going to be able to demonstrate success as a starting point. I think that's one of the things that we have learned that's very important. And here's this link to this how-to guide that you'll be able to download some of these tools that I've discovered that are really quite helpful as a resource for thinking about engagement. Next slide, please. That was it for me. So that was just a short message about how to start thinking about engagement and how to get people engaged in our work.
So thanks very much, Julie. I think that's certainly really helpful. You said that part of what you said is having different messages for different people and repeating the message. I've heard that people don't hear anything until you've said it 5 or 6 times, which is certainly how advertising works. And I know that we have a privileged role in that we get to sit and think about vision and change and how things could be and get to spend a lot of time protected from day-to-day clinical work, where other people don't have that opportunity, and therefore we've had a question come up as a change leader working in integrated care projects. The question from Anne is, the clinicians that she's trying to help change always feel that the change is being forced upon them, that they're being forced to change. Paul, you've done a lot of work with the NHS. That must be one of their concerns, that it appears to be the clinicians buck up because they're being forced to change. How do we get around that sort of feeling by our clinicians?
Yeah, and it's about engagement. What that behavior or that question or that challenge is picking up on is the value of autonomy and mastery. I'm a clinician. I'm a master of this. I see patients every day. I don't know who came up with this change, but I wasn't asked, or I don't recognize who's putting this change forward. And I wonder if those people who are putting this change forward have ever dealt with patients on a day-to-day basis. These are very common questions, and if you can't address that, then you're gonna get a behavior that you will label as resistance, but it does no good to label it as resistance. It just is what it is. And so finding ways to get large numbers of clinicians involved in the thinking process that leads to a change, using the internet to have open chat forums, to have webinars at the early stages of thinking about a change where people can comment and hear firsthand from the experts or the people who are going to be on the team. When people perceive, particularly clinicians, when clinicians kind of perceive that something was decided behind closed doors through some magical process that they weren't involved in, they naturally have questions. So you have to go back. If you're facing that kind of resistance at the point of you've already decided what the change is, then you've gone too far. You should have involved the clinicians earlier in coming up with what the change was. I don't know, Julie, you want to comment on that?
I mean, I agree with you. I'm curious if there are any other comments or questions to add to our conversation here, Tony.
Yes, And sometimes I think when people are sorting out a change, I'm on a lot of, we're all invited to go on committees, and people are trying to work out what changes they would like, and the committees spend hours working out models of care and principles of change and how things will look and new processes to put in place. So I'm interested in there's a bit of a dilemma there. How prescriptive should you be as a change agent? Should you be determining the processes and steps involved, and to what extent should you allow the people you're trying to change to work out where they're going to end up themselves, or to have self-determinism about their change? Do you think the balance that we tend to use, is wrong in your experience?
I think it's really hard to find that right balance. I mean, there's this pressure to perform and to perform quickly and to make progress. And then on the other hand, you're dealing with real people in their real work settings and trying to change their behavior. So I think I think I've watched people and, struggle with this again and again about just wanting to push a change through and saying that, well, everybody will come on board and those who don't want to will go elsewhere. And that doesn't feel good if you're in the middle of that, if that's what's happening to you. So sometimes a slower process, all the groundwork that has to be done in an organization to get ready to receive a change, when they're ready to receive it, then you can move forward. And I'm an academic, as you know, and a qualitative researcher. So one of the things that I've found is that a lot of this groundwork can be going into an organization and using some of those qualitative research methods by interviewing people and seeing how they feel about a change and starting to talk with them about that. And that's a way to engage people too, because once they feel like they have some input, and somebody's listening to them, and they have some input into what the change is going to look like and how it's going to affect them, and somebody actually cares about it. I mean, I think that goes a long way to getting people engaged into doing the work. It takes time, and that's, I think we're always up against that, is that there's this pressure to perform and pressure to improve, but on the other hand, it's going to take time to do it well.
Yeah, and I think too it's a false economy. You think you're doing it faster by pushing it through, but you don't have sustainability. The change doesn't actually happen, or as soon as you turn your back and move on to a new topic, it goes back the way it was before. I've talked to so many people that have said, yeah, I've sat in meetings every 2 or 3 years. We have an improvement team on topic X because we thought we solved it 2 years ago, but it's now all back the way it was before. It's because they rushed it through and they didn't get sustainability.
So, Jill, I'm interested. When we've chatted before, it's fascinating the way in your work you always ask the person affected. You talk to the persons affected. When we talked before about changing healthcare systems, you spoke to patients about whether they perceive their care as being integrated and joined up, whereas we tend to often neglect the people who are most affected by it. And it's a similar analogy here. Talk to the clinicians early and see what their views are, which is what you're saying, and then bring them on board early rather than late when we've worked everything out.
Absolutely, and I think it really fits quite well with what Paul was talking about the attractors, because I think everyone wants to be heard essentially, and so because they're committed, people are very committed to the places where they work, and if you go in and you ask them about what's important to them, that becomes an attractor, and you start to understand what their values are and what's bringing why do they come to work every day? You start to understand that if you take the time to have those conversations with them. So I think that's been, something that's really important for us. And this work that I'm doing now and evaluating this large learning collaborative, and we have 55 hospitals, and we're really trying to understand. It's like they have their improvement work, but we're trying to understand what's going on in the teams. So how are they actually working together to try to affect change? And there's a lot to be learned there, because you do get at some of the ideas about why they're resisting change and how you can help them adapt the intervention to make change that makes sense to them.
Yes, get the right person.
And if I can pick up on that point, I think one of the most successful methods of creating large-scale change that we've seen are collaboratives. And collaboratives typically have teams from multiple organizations that are working on the same topic, and they tend to work at at the level of principles. Here's the basic ideas of what you have to have, but each of you have to work that out locally as to how you're going to implement that practice or that principle of things. And I think when we over-design things centrally, when we come up with this is the right answer and everybody must do it exactly this way, when we get down into that level of detail, people push back. If we give them the basic principles, here's the 5 things that you have to manage hospital-acquired pneumonia. When we give them those 5 things and say, now you figure out how you're going to implement that locally, then they have some autonomy, and you get some level of standardization, but it's a standardization that fits the local situation, and therefore it's much more sustainable because people said, we designed this ourselves using some principles. And I think we sometimes go too far in the design of change into too much detail.
Yes, Julie, you had the opportunity to evaluate the Australian primary care collaboratives. Were there any successes or failures or lessons about change that are relevant to that part of the discussion now?
You know, there were many lessons, and I'm not. I have to. I mean, you have to remind me about what some of our lessons were. It's been a while since we've done that report, and I know that I sent it to you in thinking about this, but I think one of the key points that came from that and talking to people around the experience of the collaborative was what could we do to further engage clinicians, because that's a struggle, and that's always a challenge. And so what were the ideas to engage? People love working in a collaborative model. I mean, everybody enjoys that type of work and what that means when you come together to think about change in that way. But it's that when you go back, you know, you have your meetings and everybody gets excited, and you go back to work and you go back to your own setting and trying to get everybody else to catch on to that energy that you have, that's always a struggle. So, you know, it's easy to be excited when you're together at your collaborative meetings, and then you go back and you're faced with, okay, I'm back at work now, and I got to get people energized to do the work. And so how do you actually engage people? And that was one of the lessons learned from that evaluation that I did on the collaborative for the Improvement Foundation is we need more ideas. Now, unfortunately, the people I was interviewing didn't have the answers for how to do that, but they were identifying that as something that we really need to figure out how to address.
Thank you. We've got a couple of questions about engaging patients in the redesign of healthcare, which is something we talk about, but not something that I observe happening to any great extent. Paul, I presume the organisations you work for often say they want to engage patients in the design of their care. Have you seen successful ways of achieving that?
Yeah, particularly in the UK, a methodology called experience-based co-design, which was developed in the UK. Lynn Marr, a dear friend of mine, was one of the leaders of that, in which patients were engaged in equal numbers. So if you had an improvement team of a dozen people, 6 of them were service users and 6 of them were staff. So that you get that equal voice in there. We sometimes have. I think we think we're engaging patients in redesign because we have a token patient on an improvement team. There's 12 clinicians and members of staff, and there's 1 poor patient. And every time the patient says something, we explain to them why we couldn't possibly do that. But when they get together, when they get together in equal numbers, and they're coached and trained to speak up, to have their voice, it needs to be designed around that. We really want to hear. You get some wonderful improvement stories. A quick one that comes to mind was a hospital in just outside of London in Luton, in which they had a large number of stillbirths among a minority population, and there's lots of concern about this. And they actually engaged the women from that population and had very deep dialogues about what it was like to be someone who didn't speak English, who had a different culture coming into the health service and getting the instructions they got that they didn't understand, and just how difficult that was. And the clinicians who were involved in that said it was just an eye-opening experience. They'd never seen it from the patient's eyes before. They were so busy being good clinicians. And they were being good clinicians. There's nothing wrong with their hearts were in the right place. It's just that they weren't able to see it from another point of view. And when you bring patients in and you really listen to them, and you experience it through their eyes, you see all sorts of ways to redesign services. I'm a big advocate of the patient voice as a major driver of change and improvement in healthcare. I don't think we do enough of it.
So I've never seen a meeting where there's an equal number of users of a service as the service designers. But I can see that unless you do that, you're paying lip service somewhat to the concept.
Yeah, we have committees, and the patient engagement committee that meets once a month, and they give us some advice and stuff. But we're not letting them in to what we to what we do, and it's scary at first. In the States, the Virginia Mason Medical Center has been doing this for a couple of years. The first few times they were just so nervous that because they might not be able to answer a question that the patients had, or they might not be able to explain it. And what they found out was the patients are lovely, and they just wanted the services to be better. They just had some ideas about simple things that would make the world a better place for them, and the staff, they just never seen it. They were so busy doing what they do as professionals that they just didn't see it. And once they saw it, they said, "Oh my gosh, we can do something about that. We can make it better."
Right. I might ask you both about the role of having targets, or both having targets, and of measuring change as we go, which is something that's often not done well. Do you think that's an important part of facilitating change, of setting some goals and targets and measures, or not? What's your thinking about that? Julie.
I think measurement is important. I think we've all heard if you can't improve it if you don't measure it. We've all heard that. We've also heard that measuring the pig doesn't make the pig fatter. We've heard that one too. So it's part of the improvement strategy. Measurement's not the only thing. But it is part of the whole strategy. Finding the right measures, I think, is very important, and that's some of the work again. From working with the Improvement Foundation, I've been talking with some of your colleagues, Tony, about what we learned about giving too much wiggle room and letting teams set their own measures versus being more prescriptive and saying, okay, among these measures there's a set, and you need to choose among these, because sometimes people aren't very good at choosing the right measures, so they need help in choosing measures that you can actually demonstrate your improvement, or actually measure what it is that you're trying to improve, or if you want to compare to other people, so measures that you can do some comparisons. So I think measurement is important. Is my final answer.
Yeah, and I would echo all those points and echo the words of W. Edwards Deming about the difference between measurement for improvement and measurement for judgment. If measurement is used as write your numbers down on a piece of paper, I will roll the piece of paper up and hit you over the head with it, then measurement becomes counterproductive to improvement, because what it does is it drives creativity underground. People find a way to hit the target and miss the point. So you always want to have measurements that are aspirational. You want to have goals that are stretch goals. And I would much rather see someone get 90% of the way to a stretch goal than get 100% of the way to a wimpy goal. And when we use measurement to judge and to punish and to tell people that they're bad, we are misusing measurement. When we use measurement to say, is each and every change that we're making getting us closer and closer to where we're trying to get, and what are we learning from from these changes, then we're using measurement in the right way. And as Julie said, you've got to measure. You can't know that you've improved anything if you haven't measured anything. And at the same time, measuring only doesn't improve anything. It just measures.
Yes, there was a nice Don Berwick in a keynote given recently about the difference between measurement as quality assurance process and measurement as quality invention or fostering innovation, and how we need to work down what Julie's fun end of the curve about innovation and improvement, where there's flexibility rather than the ticking the boxes for the sake of measurement, which may be the risk of a performance program or pay for performance program as a pay for improvement or a fostering improvement program. I thought that was a nice way that we hadn't had before. There's a question about influencing change in organisations that we control. That is, in integrated care, we're often trying to change the way a general practice will behave, or the way a pharmacist will behave, or the way a hospital will behave, or the way community nurses work more together. I guess, do you have any comments about influencing change where we have no direct control over that other organisation?
What do you think, Paul?
I thought you were going to go first. I'll go first. I'll go first on this one. You don't have direct control over anything, so that's a myth. To imagine you have direct control over the clinicians who are in your organization simply because they are in your organization is a bit of a myth. It's all about influence. It's all about engaging people in what they think is important and framing the change in a way that they want to come alongside you to do something that they think is important, and that they can come alongside of you to do it. It's all about influence. It's all about tapping into people's values. It's all about framing the case for change such that people put their discretionary effort into it, whether it's in your so-called organization or some other organization. I think doesn't matter that much. CEOs, chief executives of organizations don't have that much power. They can tell people what to do, but as soon as they walk away, people will do what they think is the right thing to do. I don't know, Julie, what do you think?
Well, I love your answer. I think, you are so, spot on to say that, you don't have control over anything. It's naive to think that you have control where you, in your own organization. So I think, you're absolutely right. And I guess that is, I could add that to my list of, additional myths. And there are more than 4 myths. And one is that you think you have control. And I think it's about inviting them to the table. If you're clear about what your aim is, and if your aim is improving, the patient experience, improving clinical outcomes for patients, you invite people to that. And we're not talking about you need to do a better job. We're talking about we're all trying to work together to improve the patient experience, and what are our ideas to do that. So I think it's being clear about the aim, and then inviting the right people to the table.
All right, and I might ask you both about sustaining change. So we've all been in situations where some processes are set in place, some improvements are made, and when we revisit some months or years later, everyone's reverted back to the way they used to do things. And there must be something that occupies your mind. Paul, I'll start with you. Do you have any thoughts about how you stop people reverting back to previous processes, or can you do that? Can we expect that?
Yeah, I think you can. It's and it's often when you don't sustain change, it's because the change agents and the effort of change stop too soon. You declared victory too soon. A sustainable change is one where people's mindset is changed such that they look back at the old way and they say, that old way we used to do it was just wrong. I now believe that it wasn't, that the way we used to do it was just not right. For example, I don't see anyone advocating that we should put the mentally ill into institutions and strap them down to beds and things like that. We used to do that. and that was considered to be a good thing to do. And now people's mindsets have changed, and they say it's awful. We shouldn't have done that to begin with. So it's staying with the change long enough for people to convince themselves that this way is better. And as I've been saying over and over again, better is a decision that each and every person makes based on what they think their values are. So it's just driving that home such that they don't want to go back to the old way because it was not right. And it takes the effort to keep communicating and engaging people to get to that level.
So we won't declare victory too soon. Do we burn down the bridges so that they can't go back?
Yeah, I think that sometimes helps, particularly with technology kinds of changes. Making it impossible to go back to the old technology can cause that last little bit of the bell curve of adoption. People say, well, I guess I have to do it now. And then once they do it, they go, oh, well, actually, this was okay. It was better. I don't know why I was resisting so long anyway. So I think that sometimes helps.
It's really about changing the culture, isn't it? And you know, if you want to sustain the changes, then it has to be embedded in the culture. And I think, you know, as you say, it's often that we've declared victory too soon, and that we move on to the next thing without making sure that we've actually, you know, had a cultural shift. And so it's, you know, it's thinking about, you know, it's not just a series of individual quality improvement projects, but it's a whole system, a systemic approach to thinking about improvement work and how they all fit together and are interlocked in our system.
Absolutely. So changing the culture and the mindset. Look, there are no more questions that I can see coming through from our panel. Julie and Paul, you've given us plenty to guide our change efforts and to think about. Having an appropriate vision, having some key themes rather than a detailed analysis of processes, allowing the people who are going to be affected by the change to have significant involvement from the get-go about designing the change so that they get more commitment, particularly about realising that we don't control other people and we need to get the attractors right, and if change isn't happening, we need to understand the people that we're trying to help improve, not keep representing the same information. We need to make it fun. We need to understand the role of measurements and targets being used for innovation rather than for whipping people over the head, and how to deal with those obstinate or people we see as obstructionist or restrictive, and strategies to deal with that, and then some ideas about how we can sustain change, not declaring victory too soon, but to continue to support change going forward. Were there any other points that you think that we may need to add before we close? Julie?
I think those are all important points, and I don't think the conversation's over. So I'm really looking forward to the chance to talk about these some more in November at the conference. I'm excited that I'm going to be coming to Melbourne to participate in the conference, and I'm really looking forward to this. You know, I was living in Australia until about this time last year, so this will be my first chance to get back, and I'm really looking forward to it.
Excellent. And Paul?
No, I would say almost exactly the same thing Julie did. I've not lived in Australia, but I've visited a couple of times, and always loved the hospitality and the warmth of Australia. Melbourne's a beautiful city. I enjoy it a great deal. Looking forward to meeting people at the conference. Please, you've now seen Julie and I. You see what we look like. Come up to us at the conference and say you were on the webinar and challenge us or ask questions or if we can help in some way. You know, I often tell people that, and I just had my 60th birthday just a few weeks ago, and you know, we're all going to inherit the healthcare system that we create over the next 5-10 years or so. We're all going to be either the beneficiaries of it because we made it better while we were here, or we're going to be the victims of it because we failed to make it better while we were here. So if there's no other reason to want to engage in improvement and change in healthcare, it's the selfish reason of someday you're going to need the services yourself. So I hope that kind of motivates us all to want to make it better. There's nothing more precious than health, and therefore nothing more precious than health services to help us sustain that. I'm looking forward to meeting everybody when I'm in Melbourne.
Well, thank you very much, and that's fantastic. Brian and Julie referring to the International Improving Healthcare Conference, which is in Melbourne in November. Brian will put up a slide with more information about that, and we hope to see you all there. Early bird registration is still open, and as a member of the QI community, and you are a member of the QI community, if you manage to join this conference, then there's member discounts. So we all look forward to seeing you at the conference. We thank you, Paul and Julie, for staying up so very, very late in Washington and Chicago. It's been fantastic to have you on board. Thank you, Brian, at QI Community Central for coordinating all this, and we thank all our attendees and change leaders for listening, and we hope you all get the chance to go out and improve the healthcare wherever you are.